Hi, Dr. Brian Koffman, and I'm picking up here with my friend Dr. Adrian Wiestner from the NIH, and we're at ASH 2013 in cold New Orleans. So we were talking about the factors that predict your outcome with CLL, and I wonder if you could play out for us a little bit about the difference between predictive and prognostic factors. I know that there's a lot of overlap, but I think it can be important for patients to understand the difference.
So typically we talk about prognostic factors as markers of the disease that will prognosticate, will tell us about the disease course. And these are elements that are inherent in the disease, like is it Ig mutated, Ig unmutated, may be the best, in that sense, prognostic marker, because it tells us about the different rate of growth, the different rate of progression. So this would be a strong prognostic marker. When we then use a treatment, the question comes, will the treatment work? And potentially also, what after treatment will the benefit last? So one of the best predictive markers of things going well after treatment is what response you achieve with treatment. But other predictive markers of what...
So let me just stop you there. So that's what you're saying is that's where if we get to MRD negativity, we know that those patients tend to do much better than patients who don't get to MRD negativity.
Right, right. And if we talk about specific treatments and tailoring treatment, then these predictive markers that predict who would particularly benefit from one treatment versus the other, they still really have to be worked out. But one predictive marker has been 17p deletion for a while, predicting inferior response to our standard treatments with chemotherapy. Now, interestingly, the initial experience with the novel agents is that we have to reassess these predictive markers, in that patients with 17p deletion can respond very well and can respond durably to targeted agents.
Let me stop you there, because didn't you do some research that showed very similar responses in the 17p in your trial out of the NIH? Weren't the responses in the 17p very similar to the rest of the population?
Yes, that's correct. So
that was an ibrutinib trial, right?
That was a trial with ibrutinib, and we saw that patients with or without 17p deletion respond very well to the drug. So if we reassess responses at 6 months, there's no difference between these two groups. It's also been seen in other studies with other kinase inhibitors. However, as the follow-up becomes longer, we still see that 17p probably will predict for a higher risk of relapse or breakthrough through these novel therapies. And so you could start saying that patients with the 17p deletion, especially patients who are relapsed refractory, are maybe the ones who would benefit from combination therapy of novel agent with additional novel agent, or novel agent as a bridge to transplant. So these are things that will need to be worked out.
So I see the 17p, besides just being a bad player in itself and making the whole apoptosis process much more difficult to get going, also being a marker for genomic instability, which increases the likelihood, if you have a significant clone left, of the clone finding a way around a blocked pathway. Is that a naive understanding of what's going on? Is that part of the picture?
No, I think that's a very astute observation and a very biologically important consideration to make. Let me maybe, just in the interest that I don't forget this, point out that 17p deletion is not the same in every patient, and that the importance of the 17p deletion is greatly influenced whether it's happening in CLL that's Ig mutated or Ig unmutated. But I think it gets back to the point you made.
Let me stop you there. Does it also make a difference whether it's de novo or whether it's acquired?
Probably.
Yeah.
Yes.
Because I understand that some of the de novos do very well. They can stay disease-free for years before they progress.
I think in our experience, most of those are patients with the Ig mutated
okay. All right.
CLL.
All right.
And so patients with a 17p deletion, especially if the clone size is low.
And what's low? What's a number?
In a published study from Mayo and MD Anderson, the cutoff was at 25%.
Oh, okay.
So many of those patients actually can have a CLL that's not vastly different in its rate of progression or aggressiveness pre-treatment than other patients that don't have the 17p. So then as a prognostic marker, that 17p in those patients is actually not as informative or indicating such a bad prognosis as sometimes patients fear they have. If we treat with alkylating agents, I think the prediction that these cells do not respond as well to classic chemotherapy still holds true.
Let me ask you, the other thing that you talked about was the amount of disease left. And this is a recurrent theme with these new drugs. Unlike imatinib, which gets you down to very, very low levels, unmeasurable levels of disease in most patients with CML, the new class of drugs, almost all the patients have measurable disease, 2 years out. Even the ones who've progressed fabulously and feel tremendous. That makes me worried that there's a significant clone and that it's going to mutate and find a way around it. And, but other people have thought, no, we got to just change our way of thinking. It's a different issue. The whole issue of minimal residual disease is out the window with these new drugs. So can you address that? I know that we don't have an answer yet, but just what your thinking is.
Well, I think over the next couple of years we'll certainly clear this up better. Right now I would go with exactly what you said, that it can go both ways. We have a hard time separating which is the component we should really be worried about. What's clear at this point is that, as you said, most patients with the novel agents being the kinase inhibitors don't really clear CLL within their first 2 years, at least do not get to MRD negative disease. I would make the case that reaching MRD negative disease is a prerequisite to cure. The kinase inhibitors, maybe they just take 4 years. Maybe they never achieve that. But then if there is a drug available that one could stay on forever with, like statins, aspirin, beta blockers, then cure may actually not be necessary, right? You could always have these cells around, which would mean you probably would always have to take the appropriate drug. So the question there becomes, well, is that financially possible? Is it possible from a safety aspect, which so far we have very little indication that it could not be tolerated for long, because people have been on it for a couple of years, and many patients do not report any side effects. There are some, yes.
Usually at the beginning they have the GI issues and stuff like that.
Side effects are more common at the beginning, certainly,
right.
Yes. And the other aspect is what will really be the function of the immune system if you are on these type of drugs for years. For some of these we may be concerned about maybe an increased risk of autoimmune type complications. Maybe others, there's the question, do we eventually get some infections?
Let's hold there for a sec because I want to follow up on that. Thanks.